Hello, everyone. Welcome back. As usual, we're going to start with a question. So, a 7-year-old girl is evaluated for a heart murmur heard during a school physical. She has no symptoms. Physical exam reveals a systolic ejection murmur at the left upper sternal border. So, that's at the pulmonic area, right? The area that they described. She also has a fixed wide split of S2 Hassan, right? So whenever you see fixed wide splitting, you're thinking of atrial septal defect. Echocardiography shows a defect in the region of the fossa ovale. So that further confirms that this is ASD. Which complication is most likely if this condition is left untreated? So most likely the best answer there will be pulmonary hypertension with shunt reversal, which is what we call Eisenmenger syndrome. So let's see why. So from the previous cardiac embryology, we started talking about heart morphogenesis. We've already talked about primitive heart tube. We spoke about cardiac looping. And please, if you've not watched that lecture, make sure you watch that lecture to see what we spoke about on primitive heart tube and cardiac looping. But today, we're going to be focusing on atrial septation. So that's what we're going to talk about today. So with atrial septation is the process whereby we divide the primitive atrium into two so that we can have left and right atrium. And this process usually occurs between weeks 4 to 6 of gestation. And this involves a coordinated growth of septa and fusion with endocardial cushion. So we need endocardial cushion for this process to occur. So let's look at the steps that are involved in it. So let's look at this diagram. So the primitive heart. So in the middle here, we're going to have the endocardial cushion. So that's going to be the endocardial cushion. So the lower part is going to be the primitive ventricles, and the upper part is going to be the primitive atrium. So our goal is to divide the common atrium into two so that we can have the right atrium and the left atrium. So it's going to be the right side of the heart, and then this is going to be the left side. So the first step in the process is from the roof, right? We're going to have the appearance of the septum primum. So it's going to be the septum primum. Going to be septum primum. And this septum primum is going to continue to grow towards the endocardial cushion. And then the space between this septum primum and the endocardial cushion, so this space, right, this opening, we're going to call it what? We're going to call it ostium, right? So that's going to be the ostium primum. That's going to be the ostium primum. And then with time, this septum primum is going to continue to grow towards the endocardial cushion. And as it's growing towards the endocardial cushion, you can see that the ostium primum is becoming more narrow. But guess what? To be able to allow continuous right to left shunting of blood, then programmed cell death, which is apoptosis, is going to punch a hole, is going to degenerate part of this septum primum, right? And this new opening that's being formed is going to now be what? So remember, this is a new hole, so this is going to be ostium secundum. So down to be ostium secundum. And of course, this ostium secundum is going to facilitate the right to left shunting of blood. And as this continue, the septum primum, which is the red one, is going to continue to grow towards the what? Endocardial cushion. So to fuse with the endocardial cushion, thereby eliminating the ostium primum. So that means there will be no ostium primum anymore. And then now, this part of the septum primum is going to continue to what? Degenerate. And now, we're going to have a new septum that is going to appear from the roof. And this new septum is going to be the septum secundum. So this septum secundum also will be going towards the what? Endocardial cushion. So this red one, this green one is going to be septum secundum. And of course, the red one is still remain our septum primum. And then the space between, so this opening now between the septum secundum and septum primum, so this space now is going to be what we call foramen ovale. So this new space is going to be foramen ovale, right? And that's how we're going to form the what? Atrial septation. So now we have the right atrium and then we have the what? Left atrium. So when this so during in the utero, so let's assume that we already form our ventricular septum, right? Let's assume that we have the tricuspid valve, right? So that will be tricuspid valve, and let's say we have the mitral valve, right? So tricuspid valve. And then leaving, so blood from this, so this is going to be the right ventricle and going to be the left ventricle. So the blood that's coming from the right ventricle, right, is going to go into the pulmonary system. So it's going to go into the pulmonary artery, and then from pulmonary artery, it's going to go to the what? It's going to go to the lungs for oxygenation. But in the utero, right, during the fetal life, the resistance inside the lung is really high. So there's increase in pulmonary vascular resistance, right? Because while they're in the utero, right, so there is hypoxia there in the lung. And as we know, hypoxia everywhere in the body will cause vasodilation. But in the lung, is going to cause what? Vasoconstriction. So that will increase the pulmonary vascular resistance. Because when they're in the utero, there's a lot of fluid inside the lung, thereby increasing the what? The resistance. So because of that, the blood will not be able to go to the lungs. So that means those blood will be shunted to what? They'll be shunted from the right to the left because of increase in the pressure on the right side. But what happened when the baby is born? So as baby is born, those fluid will leave the lung and then the baby will start to breathe. And as they're bringing in oxygen into the lung, that's going to correct this hypoxia. So now we're going to have vasodilation. So that will decrease the resistance inside the pulmonary system. And as we're decreasing this pulmonary vascular resistance, that means the pressure on the right side is going to decrease. So we want to have decreased pressure on the right side of the heart. And then once the pressure decreases, the pressure on the left side is going to also what? Increase. So the pressure on the right will decrease relative to the left-sided pressure. So because of that, because of the increased pressure on the left side, this is going to push this, is going to push the septum primum against the septum secundum. And then once you push this septum primum against the septum secundum, then that's going to close the foramen ovale. And then once you close that foramen ovale, then that's going to become what? That's going to become what we call fossa ovalis. And that's how we form the what? That's how we form the atrial septum. So that's atrial septation. So moving on. So let's now talk about pathology that could arise as a result of these, right? So the first problem we're going to talk about is patent foramen ovale. So if there's a patent foramen ovale. So what's patent foramen ovale is the failure of the septum primum to fuse with the septum secundum after birth. Because once the baby is born, the septum primum should fuse with the septum secundum, thereby closing off the foramen ovale. But if this fails to happen, then we're going to call it what? Patent foramen ovale. So let's see problem that this could lead to. So most of the time, these patients, they are usually asymptomatic, but of course, this could also lead to problem. So let's go back to our diagram. So this is going to be the right ventricle, and this is going to be the left ventricle. And here we have our endocardial cushion somewhere around there. And this is going to be our septum primum. So that's septum primum. And this is going to be the septum secundum, right? That'll be septum secundum. And here is going to be the tricuspid valve. And this is going to be the mitral valve. And then bringing in blood. So this is going to be the right atrium. And this is going to be the left atrium. And then bringing in blood into the heart will be our superior vena cava and inferior vena cava. So normally, deoxygenated blood, like we know, the deoxygenated blood will come in through the SVC, IVC, and that will go into the right atrium. Then through the tricuspid valve, is going to go to the right ventricle, right? And then from the right ventricle, where is it going to go to? So it's going to go through the pulmonary artery, and then from pulmonary artery is going to go to the what? To the lungs for oxygenation. So from there, it's going to go to the lungs, right? For oxygenation. And then after those blood has been oxygenated in the lungs, then those oxygenated blood now, they're going to now return to the what? They're going to return to the left atrium, right? And they usually return through the pulmonary vein, right? And from the left atrium, those oxygenated blood, they're going to go through the mitral valve, going to the right ventricle, right? And then from the right ventricle, they're going to now go through the what? Aortic valve, right? And they're going to go through into the aorta, and then from the aorta, they're going to go to the rest of the what? To the rest of the body to supply oxygenated blood to the body. So if this patient is born and there's failure of fusion of the septum secundum with the septum primum. So now we have what? We have what we call patent foramen ovale. So some of the problems that could arise from this could be paradoxical embolism. So what's paradoxical embolism? So this is somebody who have a blood clot in their leg. So if somebody have a blood clot in the leg, which is what we call DVT, deep venous thrombosis, or if they have a blood clot in the upper limb, so that blood clot is going to travel, right, through the IVC, right? And then from there, it's going to go into the right atrium. And that blood clot is going to go into the right ventricle. Then from there, it goes into the pulmonary and it goes into the lung. And that could lead to what? Pulmonary. So we're going to call it pulmonary embolism, right? So ideally, that's usually the path for the deep venous thrombosis. They normally go into and that's why we treat DVT so that it doesn't lead to what? Pulmonary embolism, because that could lead to pulmonary infarction, that could lead to pulmonary hypertension. But if somebody have a hole in between the hearts, so instead of the blood clots to go into the lungs, that blood clot could travel from the right atrium and it could pass through this foramen ovale and then go into the left atrium. And then from there, it can go to the right ventricle. And then from there, it can go out through the aorta and it can go to the brain. And if it go to the brain, it can lead to what? Stroke. And that's what we call paradoxical emboli or paradoxical embolism. And then one of the things that could make this worse is if somebody is doing Valsalva maneuver, right? Remember, with valsalva maneuver, that could increase the intrathoracic pressure, and that could increase the resistance on the right side. So because of the increased resistance in the pulmonary pulmonary system, then that could transiently increase the pressure on the right side. Thereby, instead of that blood clot going to the lung, that will favor the blood clot travel from the right atrium into the left atrium. So that's one of the things that we can see in this patient. The other thing you can also see in this patient, so let's say somebody have patent foramen ovale that's never been diagnosed. They didn't know they have it. And now they are now sick, and maybe they have a form of respiratory failure. Maybe they have like a pneumonia, and they develop acute respiratory distress syndrome. So they develop ARDS. And now they end up on a mechanical ventilator. So you put them on a mechanical ventilator, which is a form of positive pressure ventilation. So if you put them on too much of PEEP, right? So if you give them a lot of PEEP, that PEEP could increase the intrathoracic pressure. And because of the increase in intrathoracic pressure, that will lead to increased right-sided afterload. So that will increase the afterload on the right side of the heart. And because of the increased pressure on the right side, that could cause right to left shunting of blood. And what type of blood will be shunted from the right to the left, from the right atrium to the left atrium? Deoxygenated blood. So deoxygenated blood, because the blood cannot go into the lungs, and now that blood will be moving from the right atrium into the left atrium. And those deoxygenated blood now will end up in the left ventricle, and that could go into the system. So that could cause worsening hypoxemia, right? So increased PEEP, right, on the ventilator could lead to worsening hypoxemia due to increased cardiac shunting of blood. And also, there's also been some proposed link between migraine and aura with patent foramen ovale, because shunting of microemboli into the brain. So how do we diagnose this? So the way we diagnose this, we do what they call echocardiogram with bubble. So we do bubble study. So you can do the bubble study, either you can use air, or you can use contrast with the bubble study. But remember, you don't want to use air with your bubble study if somebody is pregnant, right? You don't want to do that. So in that case, you may have to do what? Contrast. But we can use contrast for your bubble study. And what you're looking for is that you get a saline, right? So you have your fluid, your saline, you put a little bit of air or contrast in it, and then you agitate it together. So you agitate it and you push it through the what? Through the vein, through the IV. And then guess what? So those agitated saline now, right? So they're going to come into the vein, and then from the vein, they're going to go into the right atrium. From the right atrium, they go into the right ventricle. So ideally, they're supposed to go into the lung and dissipate inside the pulmonary system. But if somebody have a hole in between the heart, for instance, like in the case of patent foramen ovale, so those agitated saline now is going to cross through this hole from the right atrium into the left atrium. And then when you are doing the echocardiogram, you're going to see those bubbles moving from the right atrium into the left atrium. So that will tell you that this patient is having what? Intracardiac shunt. So that's how we can make the diagnosis. The other way, you can also do transesophageal echocardiogram, whereby you can see the direct visualization, you'll be able to see it. So how do we treat this? So if patient is asymptomatic, right, you can leave them alone, right? So no treatment. But if they have history of stroke, right, or systemic embolization, then they might need what? Anticoagulation, so like antiplatelet anticoagulation. And if they're having recurrent emboli, then you might need to close it. So you might need to do percutaneous patent foramen ovale closure device. And then one of the score that you can use to be able to determine if they need closure, which is the what we call the ROPE score, which is risk of paradoxical embolization score. So if they have more than 7 on that score, then that means they will benefit from what? From closure, right? Especially in somebody who have cryptogenic stroke. So cryptogenic stroke is basically stroke in a patient who have no risk factor. You can't find what's causing their stroke, why they're having ischemic stroke. So that's patent foramen ovale. So moving on to the next pathology, which is atrial septal defect. So this is not because of failure of closure, because there's a difference between failure of fusion of the septum primum with the septum secundum from atrial septal defect. Both of them are two different pathology. So with atrial septal defect, so this is an abnormal opening in the intra-atrial septum that allows blood pass between the left and the right atrium. This is responsible for about 10% of all congenital heart disease and is more common in female infants. So we have some condition that could be associated with this. So for instance, if mom is drinking a lot during pregnancy, so that could lead to what? Fetal alcoholic syndrome, right? Down syndrome could also do it. So Down syndrome is actually a problem because Down syndrome is a problem with endocardial Cushing. So in patients with Down syndrome, they could have endocardial Cushing defects. And if the endocardial Cushing is affected, if you go back to our previous diagram, right? So if there's a problem with the let me go back to our previous diagram. So if there's a problem with the endocardial Cushing, that means the septum primum will not be able to fuse with it. So that means with endocardial Cushing defect that we see with Down syndrome, that will cause more problem with septum primum. So that will be more of septum primum. So if you see a question and they're talking about somebody who have ASD, but their problem is more with septum primum, think of endocardial Cushing defects, like patient who have Down syndrome, right? So going back to ASD, so when we look at ASD, so it could be a problem with the Ostium secundum, which is usually the most common, or it could be a problem with Ostium primum, right? So if it's Ostium secundum, remember Ostium secundum is the one that is attached to the roof of the atrium. So that's going to be excess resorption of septum primum or inadequate septum secundum. And the location is usually the region of fossa ovalis that we saw earlier. And this is usually most isolated by itself and is the most common. Whereby the ostium primum, right? So ostium primum, like I mentioned earlier, you think of endocardial Cushing defect. So this septum primum fails to fuse with endocardial Cushing because there's a defect in the endocardial Cushing. And this is usually in the lower part of the septum, the atrial septum, because that's the area that is attached to the endocardial Cushing. So endocardial Cushing defect could be seen in Down syndrome, and those patients could also have associated AV septal defect because endocardial Cushing is involved in the atrial septation, ventricular septation. It's also involved in the formation of the valve, and this is going to be the second most common causes. So let's now see what we're going to see, some hemodynamic changes we're going to see in this patient. So let's go back to our diagram. So let's look at our diagram. So let's draw our diagram, right? So this is our SVC, IVC. This is the right atrium, left atrium, right? This is going to be the right ventricle, and this to be the left ventricle. And then the blood from the right ventricle, like we mentioned, is going to go into the what? Pulmonary artery. So it's going to go into the pulmonary artery. So normally, like we mentioned earlier, right, when the baby is born, right, after birth, right, the pressure on the left side is more than the pressure on the right side. So if you look at the pressure in the left atrium, right, it's usually around 12, so less than 12. And the pressure in the right atrium after birth is also around less than 5, right? So that means if there's a connection, if there's a hole in between the right atrium and the left atrium, so which direction the blood is going to be going through? So because the pressure in the left atrium is more than the right atrium, so the blood is going to be moving this way. So this is going to be a what? A left to right shunt, right? And then what type of blood are we shunting? So the type of blood that is going to be shunted will be what? Oxygenated blood. So that means, remember, blood is also coming from the SVC, IVC, right? And then what type of blood is coming in? The type of blood that's coming from the SVC and IVC is what? Deoxygenated blood, right? So that means because of the mixing of blood here in the right atrium, right? So in the right atrium, there has to be increase in oxygen saturation. And because of that, so in the right ventricle, there's also going to be increase in oxygen saturation. And in the pulmonary, there's going to be increase in oxygen saturation. So when you decided to do a cardiac catheterization in this patient, so you're going to see increased oxygen saturation in the right atrium, right ventricle, and pulmonary. Remember, as opposed to patient who have a VSD, ventral septal defect, which we're going to talk about later, those patients, they're going to have increased oxygenation in the right ventricle and pulmonary. As opposed to patent ductus arteriosus, the increased oxygen saturation will only be in the pulmonary because that's where the shunting of blood is taking place. So that's one that we need to remember. So increased oxygen saturation in the right atrium, right ventricle, and pulmonary artery. That's number one. Number two, so we're having a lot of blood that have been coming in, right? So blood is shunting from left atrium into the left ventricle, right? And the blood is also coming from SVC, IVC. So guess what? So that means you're going to have a lot of blood in the right atrium. So there's going to be a lot of blood in the right atrium. And then guess what? These blood are going to be passing through the what? Tricuspid valve to go into the right ventricle. So that means a lot of blood are going to be passing through the tricuspid valve to go into the what? Right ventricle. And then when does the tricuspid valve normally open? It normally opens during diastole. Very good. During diastole, because during diastole, that's when you fill in the ventricle, and that's when the tricuspid valve is going to what? Open. So that means these patients, they also going to have what? A diastolic murmur, right? In the tricuspid valve area, right? Because of a lot of blood that is flowing through. And where is the tricuspid area? At the left sternal border. So that's number one. So in ASD, you're going to see diastolic murmur, right? Because of increased blood flow through the tricuspid valve during diastole. Also, a lot of blood are going to end up in the right ventricle, guys. A lot of blood are going to end up in the right ventricle. So because of that, what's going to happen? So remember here we have our pulmonic valve in this area. So because of a lot of blood flow through the pulmonic valve, so that will also cause what? Increased flow through the pulmonic valve. And then when do you want the pulmonic valve to open? During systole, because that's when the ventricle is contracting and the blood is leaving through the pulmonic valve. So that means we're also going to hear what? Very good. A systolic murmur at the what? At the pulmonic valve area, right? And where is the pulmonic valve area? At the second left intercostal space. So that's where you're going to hear the pulmonic valve. So they're going to have a systolic murmur there, right? And that's what we saw in the question that we did earlier. And then with time, because of a lot of blood flow, before we talk about that, what else can we see in this patient, right? So they could also have what we call wide fixed splitting. So that's also another thing we can see in this patient. So let's see why. So when we look at the heart sound, so you have S1 heart sound, and then we also have the S2 heart sound. The X1 heart sound is usually due to closure, right? So when the valve close, they create a noise. So they make noise. So when the mitral valve and tricuspid valve closes, right? So when the mitral and tricuspid valve close, they give S1 heart sound. And as opposed to when the aortic valve and the pulmonary valve, when they close, they give S2 heart sound. So that creates S2 heart sound. So sometimes this S2 heart sound, there could be a splitting of the S2 heart sound. So it could split into two. So how did they split into two? During inspiration. Because just imagine this is our the heart is inside the what? Is inside the thoracic cage, right? Remember, the heart is inside the thoracic cage. And then under here we have the what? We have the diaphragm. So that's the diaphragm, right? So when you inspire, so during inspiration, what happens? The diaphragm get pulled down. So once the diaphragm gets pulled down, what happens? Then that decreases what? That leads to decreased intrathoracic pressure. So inspiration will lead to, so somebody is breathing passively, right? So inspiration will lead to decrease intrathoracic pressure. So because the intrathoracic pressure is decreased, that will lead to decrease in pulmonary vascular resistance. So because the resistance in the lung is decreased, that will allow more blood to flow into the pulmonary system. So you're going to have a lot of blood that are coming in from the right side to go into the what? Into the lungs, because the resistance inside the lung is low as a result of inspiration. So because of that, what are we going to see as a result of that? So as a result of that, more blood will be flowing to the pulmonary system. So that will delay the closure of the pulmonary valve. So that means the aortic valve is going to close before the pulmonary valve. And that's what we call the splitting of S2 heart sound. So that's what we call splitting of S2 heart sound. So as a result of that, that means if somebody during inspiration, the blood that's coming in from the SVC should be able to come into the right side. So, and then one of the things that drains into the SVC is what? Anybody? Jugular vein, right? So your jugular vein, right? So your jugular vein normally drains into the what? Into the SVC. So that means during inspiration, your jugular vein is supposed to what? Collapse. So if the jugular vein does not collapse with inspiration, what do we call that? What's the name of that sign? Very good. That's what we call what? Kussmaul sign. So that's Kussmaul sign. So that's jugular venous distension with inspiration. And what does that tell me? That tells me that something is impairing the filling of the right ventricle. Something is preventing the right heart from filling with inspiration, right? During inspiration. So like we're saying, so that will cause splitting of S2 heart sound. But in somebody who already have ASD, Atrial Septal Defect, like we mentioned earlier, those patients already having tons of left to right shunting of blood. So there's a lot of blood that's shunting from the left atrium into the right atrium. So they have a lot of blood. And that means because of that, a lot of blood will be going to the right ventricle. And a lot of blood will be going to the what? Through the pulmonary, right? So those patients already have what? During inspiration and during expiration, they already have a wide splitting of S2 because there's a delay in closure of the pulmonary valve always because of the tons of blood that is flowing through the what? Coming to the right side and going through the pulmonary valve into the pulmonary system. So irregardless, even if you inspire, that's not going to change it. So that's why with ASD, we see what? Wide, fixed splitting, right, of S2 heart sound. So which is another thing that we see in this patient. And then with time, as a lot of blood is flowing through this pulmonary system, right? So what's going to happen? So a lot of blood is flowing through it. So with time, right, now that's going to lead to what? Remodeling of the vessel. So there's going to be things like smooth muscle hypertrophy, because if you remember hypertrophy, hyperplasia, if you remember when we talk about cellular adaptation, one of the things that we mentioned is that if you put too much stress, right, in this case on the blood vessel, for instance, if you put too much pressure because of increased blood flow, that could lead to cellular adaptation. So here, there's going to now be remodeling of those what? Of those pulmonary artery, right? So there's going to be things like hypertrophy, hyperplasia of those smooth muscle. And guess what's going to happen? That will lead to narrowing, right, of the lumen of the pulmonary artery. And because of the decrease in the diameter, right, because of decrease in diameter of those blood vessels, that is going to lead to increase in what? Resistance. So that will lead to increase in pulmonary vascular resistance. And because the resistance is increasing, that will lead to increase in pressure. So that could lead to pulmonary hypertension. So those patients could develop pulmonary hypertension. And guess what? This pressure will continue to increase to the point whereby the right side have to also increase its pressure to be able to push the blood into the pulmonary system. So because of this, this is going to lead to what? Increased pressure in the right ventricle, and that will lead to increased pressure in the what? Right atrium. And the pressure in the right atrium will continue to increase to the point whereby that pressure now in the right atrium is going to be more than the pressure in the left atrium. And once that happens, the left to right shunt will now become what? Right to left shunt. And guess what? What type of blood is going to be shunting now? So the type of blood that is going to be shunting from the right to the left is going to be what? Deoxygenated blood, right? So now deoxygenated blood, now we have the opportunity of going into the systemic circulation. And at that point, patient is going to develop what? Cyanosis. So that's why ASD is a cause of late cyanosis. So those patients is not going to develop cyanosis right at birth. But if this is not addressed with time because of the pulmonary vascular remodeling and pulmonary hypertension, and that will now lead to what? The initial left to right shunt will now become what? Right to left shunt. And at that point, they're going to now develop what? Cyanosis. And this process whereby a left to right shunt become right to left shunt is what we call what? That's what we call Eisenmenger syndrome. So that's what we call Eisenmenger syndrome. So like we mentioned, so the pulmonary vascular remodeling leads to pulmonary hypertension, right, during the late stage of this disease. And an increased right-sided heart pressure leads to reversal of the left to right shunt to right to left shunt. And that could lead to what? Late cyanosis. And remember, with cyanosis, right, that could lead to what? That could also cause hypoxia. It could cause tissue hypoxia. And like we know, hypoxia can stimulate production of what? Erythropoietin from the where? From the interstitial cells of the peritubular capillary. So that's why this patient, they're going to also develop what? Polycythemia, because the erythropoietin is going to stimulate the bone marrow to make a lot of blood cells. So this patient, they're going to develop what? Polycythemia. So moving on, guys. So what are the clinical findings that we can see in this patient? So we already covered most of them already. So what are the clinical features we're going to see in this patient? So we covered most of them already. So this patient, often they are asymptomatic in childhood. With time in adulthood, they could develop exercise intolerance, dyspnea, fatigue, palpitation. So they could develop tachyarrhythmia, particularly the atrial arrhythmia, right? And the most common is usually what? Atrial fib. And this could persist even after the closure. They could also have, we spoke about this already, they could have fixed wide splitting of S2 Hassan. They could have systolic murmur, right, because of increased flow across the pulmonary valve, right, not the ASD itself. And they could also have diastolic murmur because of increased flow across the tricuspid valve. We spoke about that. So how do we going to diagnose this? So the way we're going to make the diagnosis is echocardiography, right, which is the gold standard. And they can also do the bubble study that we spoke about earlier to see if there's any shunting of blood between the right atrium and the left atrium. On EKG, you can see things like right axis deviation or right bundle branch block in those patients. So what's the treatment? So if it's small, like if they have very small ASD, you can just observe them because most of the time they close spontaneously, right? But if they have significant shunts, then you can do percutaneous or surgical closure. So percutaneous means transcatheter device closure. But this is very important, guys. This is important. if that patient already developed Eisenmenger syndrome, whereby they started having right to left shunting of blood, or if they have severe pulmonary hypertension, do not close it, right? Because they already have what? They already have right to left shunt. Because if you close it, this patient might what? It might lead to decompensation. Because, for instance, let's say somebody already developed pulmonary hypertension, whereby now the blood is having trouble going into the pulmonary system, and now the only way the blood can go through is to move from the right to the left. And now you now decide to go and close this. That could lead to what? That could create more problem for the patient. And it's important, once they develop Eisenmenger syndrome, or if their pulmonary vascular resistance is more than 8 Wool's, do not close it, right? This patient with ASD, they don't need endocarditis prophylaxis in those patients, right? So please don't forget that, because they are low flow lesion. And I know it's been a long lecture, guys. So let's do some questions together. So a 32-year-old scuba diver presents after a brief episode of unilateral weakness that resolved. Brain MRI shows an embolic stroke. So we decided to do a bubble study that shows micro bubbles crossing right atrium to the left atrium, only with Valsalva maneuver, which we explained earlier. Which abnormality explain this finding? So this patient most likely has what? Patent Foramen Ovale, right? And remember, with scuba diving, right, they could have nitrogen that could dissolve in their what? In the blood, right? And those nitrogen, they could bubble out, and that could lead to what? That could lead to air embolism. So that could cause air embolism in those patients. Moving on, so the next question is a newborn with Down syndrome is found to have holosystolic murmur, right? Anytime you see holosystolic murmur on the exam, it could be maybe because as a result of VSD, right? It could also be as a result of mitral regurgitation, or really tricuspid what? Regurgitation. So depending on where you're hearing the sound. So if I'm hearing if they tell me that it's a ash holosystolic murmur at the sternal border, then I'm thinking this could be BSD, right? If I'm hearing it at the fifth left intercostal space, holosystolic murmur radiating to the axilla, then that could be what? That could be mitral regurgitation. If I'm also hearing it at the parasternal border, parasternal area, in the left parasternal area, that could also be tricuspid regurgitation. So this patient could have any of this. But in addition to that, this patient has a fixed splitting of S2 as and we said that fixed splitting of S2 is seen with what? ASD. So echocardiogram reveals a defect in the lower part of the intra-atrial septum. So remember, in the lower part, we said this is usually a problem with what? Septum, right? So it to be a problem with septum primum, whereby the septum primum cannot fuse with the endocardial cushion. So that's which embryologic structure failed to fuse. So I think the best answer here, based on this patient likely have endocardial cushion defects. So because of the endocardial cushion defect, that leads to problem forming atrial septation, and that also leads to problem with ventricular septation. So I think the best answer there would be endocardial cushion defects. Moving on to the next question. A 16-year-old female reports dyspnea after exercise. Physical examination finds a mid-diastolic murmur, right? So since we're talking about ASD, remember we said that in ASD, if they have diastolic murmur, that's because of increased flow through the what? Tricuspid valve. Echocardiogram shows increased right atrial and right ventricular volume overload and left to right shunts. Which of the following best explain the murmur? So what they're asking us, they're not even asking us about the ASD. They're asking us about what's causing this diastolic murmur. Remember, we said that the diastolic murmur is due to increased blood flow through the what? Through the tricuspid valve. So let's say mention that this is a systolic murmur, and the systolic murmur is at the second left intercostal space, then that's going to be due to increased flow through the what? Pulmonary valve, right? Remember, that's what we saw, we discussed earlier. Moving on to the next question. A 55-year-old man presents with progressive fatigue, cyanosis of the lips. The patient has history of ASD that was diagnosed in childhood and never repaired. And a physical exam shows clubbing and a signs of right heart failure. Which of the following best explain this patient's cyanosis? So that means now that the patient is having cyanosis, it's going to be a what? A late cyanosis. And remember, I said that late cyanosis is due to what? Pulmonary vascular remodeling, thereby leading to pulmonary hypertension, increasing the pressure on the right side, and thereby the left to right shunt now becoming what? Right to left shunt. So I think the best answer there would be what? Would be C. So right to left shunt due to pulmonary hypertension, and that's what we call what? Eisenmenger syndrome. So last question, guys. A 5-year-old boy with history of frequent respiratory infection is evaluated for a heart murmur. So they didn't tell us even the location, but they gave us the cardiac catheterization. So reviews the following oxygen saturation. So let's draw our diagram. So drawing our diagram, so let's look at our diagram. So again, this is going to be the right atrium, left atrium, right ventricle, left ventricle. So the saturation in the SVC, right? So in the SVC is 68%, right? So which is because it's deoxygenated blood that's coming through them, right? But in the right atrium, there's a step up there, right? So it went up to 82%, right? And also in the right ventricle is also 82%, right? Which is similar to what we see in the right atrium. And in the pulmonary is 83%. So the only thing that could explain this, the jump between oxygen saturation going from 68% to 82% in the right atrium, that means there has to be a shunting of blood, right? Between the left atrium and the right ventricle. So that means deoxygenated blood is coming from, oxygenated blood is coming from the left atrium into the right atrium, thereby increasing the oxygen saturation in the right atrium. So I think based on that, I think this patient is having what? Atrial septal defect. So the best answer there will be what? Will be A. So for instance, let's say the question say the right atrial sat is like 68, right? 68%, but the ventricular one is one that is increased. Then this could be a case of what? Ventricular septal defect. So let's say this one is also 68%, right? But now the pulmonary artery is 83%. Then that is going to be what? Patent. That will be patent ductus arteriosus. And thank you, guys. We've come to the end of today's lecture and the questions. And please don't forget to like, subscribe, and share this video with your friends. And I will see you guys in the next lecture. Bye for now.